Good afternoon, and thank you for joining us for the fourth installment of Sickle Cell Science Path to Progress. My name is Hillary Witte-Byers, and I'm with the Engagement and Media Relations Branch at the National Heart, Lung, and Blood Institute, or NHLBI. This is the final webinar in our four-part series during Sickle Cell Awareness Month. Today's edition is Sickle Cell Disease Care in the Emergency Department, Improvement Initiatives and Ongoing Research. Before we hear from our speakers, I have just a few housekeeping items. For a better viewing experience, we recommend using Chrome or Firefox. And listeners, if you have questions throughout the session, please do send them to us via the webinar chat function, or you can email them to nhlbinews@nhlbi.nih.gov. That's nhlbinews@nhlbi.nih.gov. We'll have time to answer questions after the presentations. And with that, I am delighted to turn it over to Captain David Wong at HHS.
Thank you, Hillary. I'm Captain David Wong, Medical Officer with the HHS Office of Minority Health, and I'll be your moderator today. We are excited to be hosting this webinar with NHLBI and the American College of Emergency Physicians. This webinar is eligible for 1 CME credit through Meharry Medical College. All participants will be emailed an evaluation form within 24 hours after the conclusion of the webinar. Meharry will email CME certificates directly to those who have completed evaluations. I have the following disclosures to make for today's webinar. Today's speakers are Dr. Paula Tanabe, a professor in the School of Nursing at Duke University, Dr. Carolyn Fryermuth, an associate professor in the Department of Emergency Medicine at the University of Cincinnati, and Dr. Patricia Kavanaugh, an associate professor at Boston University School of Medicine. Without further ado, I'll pass the microphone to our first speaker, Dr. Tanabe. Thank you.
Well, good afternoon, everybody. I'm waiting to take control, and I think I'm taking control of the slides now. So I'm really privileged to be here today. I want to thank the NIH, DHHS, and ASAP for this opportunity to share some kind of ongoing initiatives in research related to sickle cell disease in the emergency department. And these are my disclosures. So in the next 15 minutes, I am going to give an update on a pilot grant that's already been conducted, an ongoing randomized control trial called Compare VOE, and talk a little bit about an upcoming project that should be launched from the NHLBI-funded Sickle Cell Disease Implementation Consortium. And I will not talk about bullet number 4. In 2014, NHLBI published evidence-based recommendations for the treatment of sickle cell disease. One of the chapters in that report was acute complications. One of the complications that is the most frequent reason for visits in the emergency department was the treatment of vaso-occlusive crisis. That chapter included 17 bullet point recommendations. And in the next couple of slides, I'm just going to highlight a couple of them and also highlight the fact that a lot of the evidence was expert panel based. One of the important recommendations in treating patients in the emergency department with pain for sickle cell is to not assume that it's always vaso-occlusive episodes. When that happens, it's very possible that we miss life-threatening complications such as acute chest and splenic sequestration. However, the majority of the time, pain is vaso-occlusive crisis, and several of the recommendations there promote rapid aggressive treatment, including from arrival in the emergency department to administration of the first dose of 60 minutes, the use of intravenous opioids, which is really important in the current context of the opioid crisis. We are treating acute pain. We are not treating chronic pain. We are not giving out prescriptions. And the evidence based on the opioids was actually strong evidence. Also included in the recommendations, which is really important, that we'll be talking a lot about today, was the use of individualized doses for a patient. The evidence on that was primarily expert panel. However, since then, additional work has been done that I will present that should increase confidence and increase the evidence level to support that recommendation of using individualized doses. The recommendations also suggested using a standard sickle cell program or protocol when that's not available. And in many emergency departments across the country, that is the case, because unless your emergency department is affiliated with a sickle cell center and hematologists who are writing individualized opioid dosing protocols for the treatment of VOE and the ED, that ED probably won't have an individual protocol. And so the background on the standard protocol then is that at least the patient gets something that would be acknowledging the fact that this is really severe pain. And then the first bullet up front is important in that oftentimes, while we want to give individualized doses, if you don't have individualized doses, you do not want to delay trying to contact a provider to find out what that is before you give anything. So you should always be treating rapid and aggressively. One of the main delays for many patients with sickle cell is difficult IV access. So one of the other 17 recommendations is the use of subcutaneous route, which is a little bit of a change in mindset for providers in the emergency department. However, it works really very well, and I think you'll probably hear some data from Dr. Fryermuth about that as well. And then again, the use of individualized plans, which is really important in the medical record when possible. And then we've sort of adapted that standard protocol to a weight-based protocol because the standard was pretty vague. So in the protocols I'm going to talk about, we have adapted weight-based. And so what I'm going to talk about now and report is the result of a pilot project that we conducted that was published in the American Journal of Hematology. This was an RCT comparing two vaso-occlusive protocols, basically what we just talked about, a standard protocol versus a patient-specific or an individualized dosing protocol. And the reason that we did this project was really to generate more evidence beyond the expert panel, which is excellent evidence, but we wanted a higher level of evidence. So this trial was conducted to start to work in that area. The primary outcome was change in pain scores from arrival to discharge between the two groups of patients randomized to either of the protocols. We also measured many secondary outcomes, additional pain outcomes, as well as hospital admission or discharge, side effects, and safety. This was an RCT in two very busy EDs in the United States. It was with adults. And we did allow each patient to contribute data for up to 5 emergency department visits in this study. The methods were a little tricky, and this is why it was a pilot study, and it was really quite successful. So you clearly cannot randomize consent, enroll patients in the middle of a vaso-occlusive crisis. So all patients were pre-enrolled in the clinic site. After signing consent, they were randomized to one of the 2 different protocols, also based on the NHLBI recommendations, which did include redosing every 20 to 30 minutes, use of sub-Q if IV was going to be difficult. Once the protocol was written by the provider that knew the patient, the protocol was loaded into the electronic health record so that when and if the patient had another ED visit, when the provider in the ED went to order, they would find that protocol, and that's what they would order. And then a big strength of this protocol was the patients were interviewed by research staff every 30 minutes from placement until discharge or 6 hours. Primary outcome, again, change in pain score until decision to admit. They actually went home or 6 hours max, and again, vital signs, safety, et cetera. We assessed 168 patients. We randomized 106, 53 to each treatment arm. Of those 26 had no ED visits. That there's a total of 62 visits actually in each arm. So for a total of 2 sites, 52 patients, and 126 different emergency department visits in which we collected prospective data. The primary outcome that this was powered for did find that patients in the individualized protocol arm had a significantly greater reduction in pain score, so 43 about to 27 decrease. While the study wasn't powered for it, as we looked at secondary outcomes related to pain, readmission, et cetera, There was a statistical difference, but again, we weren't powered for it, and so patients in the individual arm were admitted less frequently than the weight-based arm. That data was used to submit and conduct the ongoing trial now that we're calling Compare BOE, which is very, very, very similar to what we just talked about. So this is also funded by NHLBI, and we're working with the DCRI as our U24 partner on this. And the aims are very, very similar. The primary outcome is the same with change in pain score, same output, or same endpoint, admission, decision to admit, discharge home, or 6 hours max. Secondary outcomes are also the same. Our study sites include a site in Texas, North Carolina, Maryland, Cleveland, and 2 in Detroit. So we have 6 emergency departments. Again, only adults with sickle cell disease. The primary difference in this protocol from the pilot was we did exclude patients on buprenorphine or methadone, primarily because when we conducted the trial before, there wasn't as much use of those 2 drugs, and the reason to exclude is it is very difficult to come up with an equal analgesic conversion from those drugs. The protocol will enroll, we estimate, because based on the pilot study, sorry about my email there, based on the pilot study, about 1/2 of the patients we enrolled in the outpatient had an emergency department visit. So we plan to enroll 460, randomize them. Our study population will be 230 patients. And in this protocol, the difference will be each patient will be allowed only 1 emergency department visit. Other than that, once they are placed in a treatment bay, the research assistant in the emergency department does every 30-minute interviews with the patient. So we don't rely on anything from the EHR except for the medications that were given and if they were actually hospitalized. So all of the data about pain, vital signs, side effects are collected real-time prospectively from research staff. So I think that kind of summarizes it here, is it's the same thing, enrolling in the clinic, randomized, plan in the EHR, ER provider orders it, research staff collects the data. Interviews right from the patient, side effects right from the patient, safety from the patient, and we're also getting EHR review on the back end, looking for safety with Narcan, vasoactive, intubation, vital sign abnormalities. So I can update this slide. 4 sites have been activated. The other 2 sites should be activated by the end of next week. We have 20 patients enrolled, so that's a big update. And today we had our first emergency department visit, so that's really very, very exciting. Then the next and the last thing I'm going to wrap up here with really quickly is also funded by NHLBI. We are one of the sickle cell disease implementation consortium sites, and it's really important that I highlight implementation. So there are 8 sites enrolled in this, and there are many purposes for this grant, including enrollment in a registry, but also each site has to conduct 2 of 3 implementation projects. And the one I'm going to talk about today is the ED. You can see the sites here. These are the 8 sites that are participating in the implementation consortium. The ED project I'm helping co-lead, and that will launch in January. And the goal of this is to improve, again, BOE management. Again, we want to implement individualized pain plans. Because this is implementation science, we want to assess patient efficacy or patient-perceived quality of ED care as a primary outcome. We will also assess provider outcomes. We're looking at many system outcomes, and it's being guided by REACH. The intervention for this, what's very different than the other project and has never been done anywhere that is incredibly exciting, is that not only are individual plans, and this project will be only individualized plans, will be written, placed in the EHR for the provider, but also placed in the place in the EHR where the patient can access it wherever they are. So in the future, they would be able to walk into any emergency department, pull up their electronic health record on their phone, and show it to the ED provider to look much more legit than some past efforts where a patient may bring in their protocol on a letter. So research staff are going to enroll patients, help them download their app, so they're, in Epic, it's MyChart, and make sure that they can easily find their protocol. And we did spend a lot of time figuring out where's the right place to put it to make it easy for the patient to find it. And for the Epic, we believe it's 2 clicks. And so we have some interventions to test around that. There are some strategies to test what's the best way for them to make that happen. And with that, I'm going to click through the rest of these slides. That was that part of our study team. And I think that there's lots going on. And I think that typically we're kind of complaining about the ER all the time. And I think it's good for people to know that there are actually some really exciting clinical trials going on in implementation work to help actually make improvements in this area. And so with that, I will stop and turn it back over to Darian to move the ball. Thank you.
All right, so as Captain Wong said, my name is Caroline Fryermuth. I'm an Associate Professor of Emergency Medicine at the University of Cincinnati, and joined under Paula's wing almost 10 years ago now, doing research in the sickle cell disease community. So my only disclosure is that I do have an investigator-initiated grant from Pfizer in conjunction with the American College of Emergency Physicians to fund some quality improvement initiatives surrounding sickle cell disease at my institution. So when we talk about delivery of pain relief, this is really the #1 complaint we hear from patients. They go to the emergency department. They've already exhausted their options at home. They've taken their pain medications. They've used their alternative techniques. They come in because they cannot relieve the pain on their own, and then they are made to sit in our waiting rooms for hours and hours, or they're brought back to a room and are made to wait there, or it's very hard to get intravenous access and it delays administration of pain medication. And so one of the things that we've been trying to do is figure out, how can we improve how quickly we can administer pain medication to these patients when they're experiencing a vaso-occlusive episode. If we look back at the guidelines that NHLBI developed years ago surrounding sickle cell disease, especially within the acute management, the recommendation is that patients receive parenteral pain relief within 60 minutes of arrival or within 30 minutes of triage. And I want to emphasize the point of parenteral pain relief. As Paula said, the delivery of opioids was one of the recommendations that had the most evidence behind it. And we know that giving intravenous opioids is much more effective than giving oral opioids when someone is having a moderate to severe vaso-occlusive episode. So I work in an emergency department. I work in a very busy emergency department. We are the, safety net hospital in my region, and so we have very high patient volumes. We have long waits. Patients are boarding, waiting for beds upstairs. Patients are sitting in our emergency department waiting room, waiting to be seen. And so I am very well aware of some of the barriers that everyone faces. We know that patient volumes are high. In addition, there is not much education regarding sickle cell disease. If you look at medical school curriculums, if you look at nursing school curriculums, if you look at the core competencies in residency training for emergency medicine, sickle cell disease takes a very, very small place and is usually just lumped up under hematologic, oncologic things. And so people don't know much about the disease. It's one of these silent diseases where we see patients, they tell us they're in pain, they may not look like what we think they should look like when they're in pain. People are unaware of the high morbidity and mortality associated with that disease, and it changes people's opinions. We also know that intravenous access is a challenge. Many of these patients, as they age, have had further vaso-occlusive episodes. This has caused long-term damage to their vessels. They have had recurrent IVs placed for treatment of vaso-occlusive crisis, for transfusions, for whatever else, and this makes it more and more difficult to find an IV line in the future. And so we know this is also a delay. And I did touch on it briefly, but provider attitudes, we have done quite a few studies showing that there is a large bias against patients with sickle cell disease. We already know that patients who are African American have stigma when they present for pain-related complaints, and now we know that on top of that, that there is also stigma related to the disease itself when patients come in, and so having to overcome these barriers makes it a little bit more difficult. So when we think about how many patients we're talking about, the typical person with sickle cell disease experiences about one vaso-occlusive episode per year. So we know that there are 90 to 100,000 patients with sickle cell disease in the United States, so we're not talking an excessive volume of emergency department visits when we think about it. About 40% of patients with sickle cell disease will have 0 episodes per year, and about 1% will be those patients that you see more frequently who have up to or more than 6 vaso-occlusive episodes per year. So in thinking about how we can move these patients through faster, one of the first steps we can make is to triage these patients as ESI level 2. Most emergency departments in the United States use the ESI triage system. Level 1 is going to be those patients who are actively dying and need to be resuscitated. But level 2 is that next highest level, and we know that those patients are placed in rooms faster. And if you look at the actual criteria to meet ESI level 2 based on potential morbidity, the anticipated resources you will need, and just the pain level alone, patients in vaso-occlusive episode will meet the criteria to be triaged at this level. We also want to educate everyone that may care for these patients so they truly understand. The median lifespan for patients with hemoglobin SS disease is in the 40s. That's basically half of the lifespan of a typical American. And so these patients are dying early, and they have a lot of complications leading into that. Acute chest syndrome is the leading cause of death in this patient population, affecting 15 to 40% of patients, and it more commonly occurs during a vaso-occlusive episode. And so when we see patients, we really want to make sure that we are screening for this. We want to know, are you having chest pain? Are you having difficulty breathing? Do they have decreased oxygen saturations? Might this be an infection? Might this be a pulmonary infarct? We really want to be on high alert for this because this will kill, and this will kill quickly. One of the very few things we can do to prevent this is encourage the use of an incentive spirometer. So when you are evaluating patients with vaso-occlusive episodes, especially if you know they're going to stay in your observation unit or if they're going to be admitted to your hospital, encourage the use of that incentive spirometer to decrease the incidence of acute chest syndrome. And then just think about all of the other things that are affected. So when patients have a vaso-occlusive episode, they get these misshapen blood cells, they get sticky inside the capillaries, they stick together, they cause a lot of inflammation, they cause lack of blood flow distal to that, and so patients will have microinfarcts all throughout their body. 45% of patients with sickle cell disease will experience a stroke before the age of 45, 30% suffer from renal insufficiency, 30 to 40% will develop avascular necrosis, most commonly of their hips and shoulders, so those large joints, making it very painful to get around, and 30% will be affected by pulmonary hypertension. So this is not a benign disease process. It is a very chronic, debilitating disease. When we think about the next barrier, the intravenous access, think about going to ultrasound-guided IVs early. A majority of emergency departments now have access to ultrasounds, so think about training your nurses to use these so that they have that extra step that they can take when patients have difficult IV access. One of the other things that is recommended in the NHLBI guidelines is that if you cannot get intravenous access in a timely fashion, that you think about using the subcutaneous route to administer pain medication. This route does have similar pharmacokinetics to the intravenous route, and it avoids the pain and the potential for sterile abscesses that you see with the intramuscular route. They've actually done quite a bit of research with this in the palliative care world, and patients do tend to prefer subcutaneous over intramuscular, although it may take some patient education and some nursing education to get people to buy into this. As far as overcoming provider attitudes, really the only thing we can do is educate people and make sure that they understand that patients with sickle cell disease are sick, do have real underlying disease, and are humans just like the rest of us and deserve to be treated with respect. So my quality improvement initiative, funded by the investigator-initiated grant I mentioned earlier, was to institute a practice whereby we deliver subcutaneous opioids in triage when patients present with vaso-occlusive episodes. So I partnered with our hematology teams who said, you know, we really want to make sure that we're aware of which patients this is going to be offered to. We have some patients who are very opioid naive, and we worry about them getting opioids and then sitting in the waiting room and have adverse effects. We have a few patients who already have very restrictive care plans, and we worry that they might abuse this privilege, and so we want to make sure that we know who is going to be eligible or not. So they actually took it upon themselves to write individualized plans for all of our patients, whereby first they say eligible or not eligible, and then secondarily they determine which medication is most effective for each patient and which dose of said medication. And so we have some patients who receive hydromorphone, we have some patients who receive morphine, and they all have varying doses that are easily accessible in their electronic medical record. We educated our patients about this. We didn't want them coming to the emergency department and thinking we were doing something completely out of the realm of normal, and so our hematology team in the months leading up to the go live of this initiative educated the patients, telling them why we were doing this, what was going to happen, and really listening to their concerns. We worked with our informational technology people to make sure that we had automatic alerts embedded into our electronic medical record. So when a patient with sickle cell disease comes in and is eligible, when the nurse opens the triage screen, an alert will fire and say this person has been deemed eligible for subcutaneous opioids at triage. And then when the physician opens any part of the chart, this alert will also fire and allow them to immediately select the appropriate dose. So this is a picture of what it looks like when it fires for our nurses. They can acknowledge the reason that they closed this, although they can get by it without acknowledging a reason. So looking at our data before we initiated this, we were actually doing a really good job of getting patients back to rooms. So our median time to room placement for patients with a vaso-occlusive crisis was 7 minutes. So you're thinking, oh my goodness, these patients are getting back. You're getting them treated great. But then when we looked at it, the time to delivery of their first dose of pain medication had a median of 84 minutes. So that's a huge delay of the amount of patients that were actually getting pain control in a timely fashion, with only 31% of those who received a pain medication having it administered within 60 minutes of their arrival to the emergency department. And we did try to do some chart review, and it looks like the majority of cases it was delayed due to physician order or intravenous access. So either it took the physician a while to get in the room and order it, or it was ordered and then they weren't able to establish an IV on the patient, and so administration was delayed. So we went live in March of this year, and to date, we have not made any significant changes in those times, although it is still very new, and we are still trying to increase adherence to this new initiative. So we see about 200 patients in our clinic system here, and they deemed that 51 of these patients would be eligible for this initiative and wrote care plans for them. Since we have gone live about 6 months ago, the triage alert has triggered on 80 different visits, representing 30 unique patients. We do know that a small subset of these visits were for reasons unrelated to sickle cell disease, but a vast majority of them were for vaso-occlusive episodes and should have been eligible to receive subcutaneous opioids. Many of the nursing alerts that were closed, there was no reason selected, so it is unclear, whether they were just ignoring it, whether they told somebody and then that person ignored it. I don't have great individual data on that. And then the physician's alerts, when they triggered, 26 times out of the 80 that they triggered, the physician actually went ahead and clicked on the dose to order the medication from the actual alert that fired. So we know that the biggest barrier is speed to room placement with subsequent delay in evaluation. We specifically knew that this was a barrier, and so we asked that the triage nurse go ahead and alert someone and essentially get the medication while walking a patient back to the room. This has been a big barrier where oftentimes the triage nurse needs to get back out front to triage the next patients. And so we're working on a better system of communication whereby they can hand this off to the bedside nurse and make sure that these orders are getting placed and administered even prior to patient evaluation by the physician. So in conclusion, we know that subcutaneous administration allows for delivery of analgesia while attempting to obtain intravenous access. And we know that embedded alerts and order sets allow for ease of ordering and prompt compliance to workflows, especially for this patient population that is a little bit more uncommon. We only see a few a week, and so it's hard to keep that in the forefront of your mind. We do know that EMR alerts can fatigue people, but we felt for this specific disease process, they were essential so that people didn't forget about this. And with that, I'm going to turn it on to Dr. Cavanaugh.
Thank you for that, Caroline. So thank you so much for having me here today. My name is Trish Cavanaugh. I work in Boston at Boston Medical Center. We're going to switch gears a little bit. So Caroline Fryermuth works in the adult ED setting, and I am actually working in the pediatric setting, taking care of kids with sickle cell disease, among other things, in the pediatric ED. So I'm going to talk a little bit today about, and hopefully I'm convincing you that there's a national effort to add sickle cell disease to the priorities in the emergency department. We've made huge strides in the care of patients presenting with acute MI, stroke, sepsis over the last 20 years. We are frontline and center in really trying to get our arms around the opioid epidemic, taking care of patients who are both overdosing and then also trying to link them to detox services and even prescribing Suboxone in the ED setting. And sickle cell disease, as Caroline eloquently told us, we need to add that to the list of priorities so they understand, so ED practitioners understand the risk that this patient population has when they walk through their doors complaining of pain. So we've already reviewed a number of times here today, but I'll say it again. They always say that the third time's the charm in terms of learning, but there are clear guidelines, and there's an algorithm that's been published by NHLBI 5 years ago now that really outlines beautifully what are the key steps that need to occur with respect to taking care of patients presenting with a vaso-occlusive episode. So number one is to triage as a high priority. And we've talked about this emergency severity index, number one being in the trauma bay, number two being at very high risk, either from their presenting complaint or from other complications. So this is in the guidelines of ESI. We should be checking for other complications. So as Caroline was talking about, we need to evaluate if they're having chest pain, looking for acute chest or pulmonary embolism. You're thinking about pain that doesn't quite, not as consistent with their typical pain episode. You might want to think about sepsis, sometimes presents with all body pain. Headache, you know, it's hard to look at a young adult, a 20-year-old with a severe headache and think of stroke, but they are at high risk of a hemorrhagic stroke at that age group. In the younger children, especially under age 10, or in the older adults, ischemic strokes, unfortunately, are common. And then abdominal pain can be a number of things, including splenic sequestration or cholecystitis, as so many adults will have their gallbladders taken out, but these gallbladders become problematic in children even as young as 8 or 9 years old. The third thing is to really treat the pain aggressively. So beginning analgesic management within 30 minutes of triage or 60 minutes of registration is a quality measure that has been developed and is actually included in the NHLBI guidelines. And to really administer these opioids quickly, so very quickly at the beginning, but then frequently reassess and readminister dosing every 15 to 30 minutes until pain relief is obtained, and really letting the ED providers know that they can increase that initial dose given by 25% if it really had no effect. And then, of course, include non-pharmacologic approaches such as heat and other distraction techniques. Someone who's playing a game on their phone or talking to friends is not comfortable. That's distraction. That's what we encourage women who are in labor or other folks who are experiencing extreme pain. We encourage the use of distraction as a way to manage pain. And then lastly is to begin patient-controlled analgesia in the ED if and when are possible. So I'm going to talk a little bit about the work I've done at Boston Medical Center, just a little bit about the setting. So we have almost 500 beds. We work in the inner city. We're the largest safety net provider north of New York City. Over 90% of our children that we care for in between our clinics and the ED have Medicaid. The motto of our hospital is exceptional care without exception. So we have a large immigrant population. We have 24/7 interpreters for Spanish, for French Creole, for our Haitian population, and Portuguese Creole, since we have the largest Cape Verdean population in the United States. The opioid epidemic is centered around our institution, and all providers and staff carry Narcan. I actually just picked up my latest box set in the medical school lobby last week, because we do use it, unfortunately, to potential patients outside our doors. We're a level 1 trauma center. We have over 140,000 visits a year, and we also are a comprehensive sickle cell center caring for approximately 450 children and adults with sickle cell disease in our institution. So back in 2010 and 2011, when I first had the idea of really trying to improve ED care, given that just like the adults, it's the #1 source of concern for patients, whether they're children or adults with sickle cell disease. In order to make changes in the pediatric ED, we really need to form a multidisciplinary team. The ED providers can't do this alone. They really do need the input of hematology. And what we did was we actually formed a team that included the hematologists and ED doctors, but then also included nurses, social work, and then the ED pharmacy was critical in terms of what medications could we have access to quickly in the ED setting. We wrote a protocol based on the NHLBI guidelines, which I'll show you in a minute. And then, as we have been talking about, we did a lot of education because a lot of ED providers really have not been educated extensively on this condition, especially when it presents in the emergency department setting. So for the nurses, we actually did a lot of face-to-face check-ins and education. We came in the morning when they were doing change of shift, in the evening, and even in between. And then we also did a lot of teaching with residents and attendings. One thing I forgot to add to this slide is we actually educated the patients and their families as well. And so that education took place in the pediatric hematology clinic so that patients and their families understood this was a joint venture. It wasn't just the ED changing protocol. It was actually being done in close coordination with the hematologist. And so the protocol that we developed started off with an ESI-2. So if you designate them at this high severity level index, they are put into rooms preferentially above those that may have lesser concerns. And so these patients are put into rooms. The goal is to get them into a room within 15 to 20 minutes of arrival so that they can be assessed quickly. The only way we're going to get a dose of a parenteral analgesic into a patient quickly is to have them triaged quickly and then placed into a room quickly. The second piece is we actually did a slight modification for children with sickle cell disease on the parenteral analgesics chosen. So we actually start our protocol with 2 doses of intranasal fentanyl. This is a medication that is used by many pediatric EDs across the country, and I'll explain a little bit more in a moment. You can give 2 doses, 5 to 10 minutes apart, and then you can follow that with 2 doses of IV opioids. The reason we've started with intranasal fentanyl is that it's easily administered and can start the process quickly. For those who, at the time of disposition, if the patient's being admitted to the hospital, we actually start the PCA, the patient-controlled analgesia, in the ED setting. If they're actually going home, then we actually give them a dose of oral medication prior to discharge, wait 30 minutes to an hour to ensure that pain capture is achieved. The worst thing in the world is to get good pain control, send them home, and then within a couple of hours they come back because pain relief was not truly obtained. So starting the oral trial in the ED setting was critical. A little bit on intranasal fentanyl. So we use it in the ED to control acute pain. We often use it to set bones in the ED setting, and we actually do it for draining abscesses. The onset is 5 to 10 minutes. It actually works very quickly, and it lasts about 30 minutes. You can safely give 2 doses to children, 10 minutes apart. And we actually put this through our P&T committee at BMC, since intranasal fentanyl is an off-label use anyway, and then we just went through that committee to ensure that they understood what we were doing, that we're adding sickle cell disease to the list of indications. You can see in the images below, there's basically a small syringe attached to an atomizer. You place that in the nose and inject it. The child on the right-hand side, so this is in Ireland, ambulance drivers are now using it for acute pain in children. And you can see that it's not exactly pleasant. There is a tiny bit of burn, but it was much more acceptable to children than doing the subcutaneous route, just because, the less needles, the better. And so we found that it had really good uptake. The one downside to intranasal fentanyl is that the effectiveness of the medication is really only for young adults up to about 60 kilos because of the formulation available in the United States. So really giving, for anyone over 60 kilos, you really have to give 2 doses to equal 1 beneficial dose. So for a lot of our older teenagers who become, young men especially, we actually reach out for that IV as the first dose, but for those until that age, especially 15, 16, 17, intranasal fentanyl is a fantastic option. We also created a pain medication calculator for use in the ED. Doing a lot of math, so taking care of children requires you to have a calculator at all times because everything is weight-based, because it really does depend on, your how heavy you are. There is no standard dosing. And so what we did is we created a calculator and put it on our Pediatric ED intranet page. And this is what it looks like. All you need to do is enter at the top the patient weight and how old they are, and then all of the other doses are calculated for you. So the first block will give you your intranasal fentanyl doses. Then for those who are in still a lot of pain, the IV doses of morphine or hydromorphone are calculated, as well as ketorolac, which is often used as an adjunct. PCA doses are calculated for you, and then oral medications to start that oral trial while you're still in the ED setting. We actually print out 2 copies of this calculator, so that one is for the residents or the attendings to do the orders. The second is actually used by the nurses to double check the doses, just because a lot of the different references that they were using would give different recommended dosing ranges. The dosing ranges chosen here were selected by the pharmacy of our institution. And so this has really dramatically decreased the time to giving that first dose because everyone is in agreement of what the dose should be based on the child's weight. And then we saw great improvement. So this work was published in Pediatrics in 2015. I'm going to walk you through the results that are shown here. On the right, on the y-axis, you see minutes, which are the average in minutes. And the first set of results is really looking at the time to the first opioid administered. The blue bars are going to show you the baseline where we started prior to the implementation of this protocol. The red bars show you the results after the implementation of the protocol, and it was at a baseline period, so results over an 18-month period, in fact. So you can see the time to the first dose dropped from just under an hour to 23 minutes on average to the time to the first dose, largely represented by the use of intranasal fentanyl. The time to the second IV dose was used as a balancing measure. I was concerned that by putting intranasal fentanyl, those two doses, as sort of the first parenteral analgesic offered, that there might be a delay in placing that IV and administering other dosages that way. And instead, we saw that the time actually decreased from 106 minutes during the baseline period to 83 minutes. So this is actually giving more pain medication, 2 doses of intranasal fentanyl and 2 IV doses. The reason this happened is because everyone became aware, they were all on the same page. Sickle cell disease became like asthma. So asthma, we give 3 Combivent nebulizer treatments plus steroids. Sickle cell disease, when someone comes in pain, 2 doses of intranasal fentanyl followed by 2 IV doses. With the nurses really aware of this protocol and helping driving the ship, they're very efficient. And so the times dropped from 106 minutes to just under 2.5 hours. The disposition decisions actually dropped as well, which is not surprising because we were able to run through the protocol that much faster. So the time to admission dropped from 4 hours to 3, and the discharge decision dropped as well. The most important finding is that more children were discharged home. We were discharging only a third of patients, and it increased to just under half. And we did not see an increase in return ED visits because we were treating them more quickly. Patients, that pain control lasted. We did not see respiratory depression in the ED or in the inpatient setting, or an increase in inpatient length of stay. And so a lot of folks asked, could this be replicated in other centers? And the answer is yes. And so these 2 studies here, I apologize for the first bullet. When you go down to the second primary bullet, this study was a 1-year review of 487 ED visits of 105 patients. This was conducted at Johns Hopkins, and they implemented the same protocol using intranasal fentanyl as the first dose. And they've had very similar results, that the mean time was lower for intranasal fentanyl, 29 minutes versus 78 for IV. And the percentage that received the first dose within 30 minutes of triage was higher, 67% versus only 5%. They received their IV as the first dose. They did not see a difference in the percent admitted by first medication. They were already sending almost half of their children home from the ED. The second study was a review of 250 patients aged 2 to 21 years with ED visits for moderate to severe vaso-occlusive episodes. This was done at Emory. And what they did is they implemented a nurse-initiated intranasal fentanyl order, so the bedside nurse could actually give that first dose of intranasal fentanyl. They found that the mean time to first dose was lower for intranasal fentanyl. Again, it was less than 30 minutes from time of triage versus 77 for IV. And they found, interestingly, 16% of children received only intranasal fentanyl and were discharged home. They never had an IV placed, which is really important for a patient population where their venous access becomes that much more difficult as they get older. So these children were largely younger and had not had very many vaso-occlusive episodes in the past. So intranasal fentanyl is all they needed before they were transitioned to oral pain medications. The last study I'll mention is it was actually a project of data collection that was done in conjunction with an RCT that was being done across 20 pediatric EDs in the country. And so separate from the RCT, the investigators agreed to collect charts of 20 consecutive patients with VOE in kids aged 3 to 21 years. And they compared those who received intranasal fentanyl as their first dose, and this was implemented in 7 EDs, versus IV as their first dose, which was implemented in 13 EDs. And they found that the median time for that first parenteral opioid, again, was 25 minutes across these charts, and they found that the percent admitted, again, was lower, 49% versus 70% if they received intranasal fentanyl as the first dose. And they had those who received intranasal fentanyl as the first dose had 2.9 higher odds of being discharged from the ED versus those who received IV. The takeaway points, just before we head into questions, is that the ED providers, hopefully we've seen over the course of the last 50 minutes, we can be great partners with hematologists to improve acute sickle cell care. We have worked hard to identify institutional strengths and to make systematic changes within the ED setting, and it can be done. And so the interventions that are used in the ED today can really improve care for, in my portion of the talk, for children with sickle cell disease, and then also for adults. So for adults, subcutaneous opioids are a great option. For children, intranasal fentanyl may be a great option as well. And at this moment, I'm going to turn it back over to Captain Wong, to take your questions.
All right, thank you to our speakers for those very insightful presentations. We have about 8 minutes for questions. Before we do that, I just wanted to make sure that our audience was aware of a sickle cell disease supplement that my office, the Office of Minority Health, is sponsoring in the Annals of Emergency Medicine. And abstracts are currently being accepted until October 31st. And we'll have a slide coming up shortly that will show the website, which is the Annals website, where you can learn more details about the call for the abstracts. So as far as the questions, the first question that I have is for Dr. Tanabe. Can you explain how the pain score is calculated?
Sure, thanks for that question. We use a 0 to 100 millimeter visual analog scale. So the research assistant had the visual analog scale on a piece of paper, and the patient used just placed a mark on that. And for every 30 minutes, they started with a new piece of paper, so that they weren't biased from their previous score before that. And we actually did not have any problems with the patients being able to do that.
Okay, thank you. This next question is for Dr. Frymuth. Why do you think there's lack of education on sickle cell patients in the emergency room?
I think the biggest thing comes down to, we get educated the most on the things that we see the most. And so when our training governing bodies set the priorities for what we need to learn, they set it based on the common things we're going to see. So we need to know about chest pain and myocardial infarctions, and we need to know about strokes, and we need to know about, other life-threatening illnesses. And so when we think about it, if sickle cell disease is affecting only 90 to 100,000 patients in the whole country, then there are probably many people who never see any of these patients in their emergency departments, depending on where they train and where they live. And so most of it is just, we only have so much time in the day and so much space in a curriculum. And so, most of this is trying to squeeze it in, and we probably should target those emergency department physicians, nurses, everyone who works in areas where we know that many of these patients live.
And I believe Dr. Tanabe has something to add to that response.
Just a quick one. This weekend, the National Emergency Nurses Association has their governance body where they vote on new resolutions. And we are introducing a resolution to the Emergency Nursing Association governing body that asks ENA to disseminate the evidence-based guidelines for the treatment of vaso-occlusive crisis and to disseminate any existing educational materials and investigate the need for existing educational materials. 13 states across the country have already signed on to this, and so what that would mean if it passes on Sunday, that ENA would form a very small group to come up with a plan to actually disseminate the guidelines and educational materials to all of their members. So cross all your fingers, and hopefully that will pass. I think the implications of that could be pretty big. Thank you.
Okay, next question is for Dr. Kavanaugh. How do you evaluate opioid tolerance prior to using intranasal fentanyl?
So I will say we do not evaluate for opioid tolerance. What we do in terms of the use of intranasal fentanyl and seeing the variable effects of it, in general, if you're under 60 kilos, we actually find that it's quite effective. For those who are larger, 65 kilos, 60 or 70 kilos, then we see diminishing returns on its effectiveness. So we try to get that IV placed sooner rather than later. I will say that in my experience, if we're having a hard time getting that IV placed, even under ultrasound guidance, or we're waiting for the ultrasound to come to the bedside, a lot of patients will still take the intranasal fentanyl as a partial, for partial relief, just as they're waiting for that IV dose to be administered, just because the IV dose takes approximately 30 minutes to reach peak effect, where intranasal fentanyl only takes 5 to 10 minutes.
Okay, the next question is also for Dr. Kavanaugh. Is there any reason to restrict intranasal fentanyl use in children? And then the second part of the question might be for all panelists. Why not always have first analgesia dose as intranasal fentanyl in adults?
I'll take the stab at the first one. So I think I wish we had the concentration available that they have in Australia. Currently, so in Australia, they have a much more concentrated formulation of intranasal fentanyl available. We do not have that here in the United States. And so that is really the biggest limiting factor, because there's only so much that you can put into somebody's nose as one dose. And so the 100 micrograms is really the maximal dose that we can do, 50 mics in each nostril. In Australia, they have a formulation that's twice as high, and so that would be a great option. We just don't have it available in the United States. Some of the other medications are not being widely used in the adult ED, but I'll turn it over to Caroline in terms of intranasal medications being used in the adult ED setting.
No, I completely agree with you, Trish, that it's just simply a volume issue, and it's one of those things where, some might argue that if you're giving them something, that's better than nothing. But if we have other options like subcutaneous, then why not just go ahead and use that to give them a better dose than, to shove a whole bunch of intranasal fentanyl up your nose. And most people don't have a problem with that, but, it does cause some local irritation and some burning sensation and whatnot. And so if we can just come up with other ways to deliver it, such as subcutaneously or getting that ultrasound-guided IV, then that's going to be better in the long run.
Final question is for all panelists. In this era of the opioid crisis and generally decreased desire to use opioids, how can we encourage early use of opioids in the face of no objective evidence to determine if the patient has VOC versus exacerbation of chronic pain?
So this is something I feel pretty strongly about, is we should just trust people. I don't know when we got into the business of determining who's lying and who's trying to pull one over on us. I don't often hear people say, well, how do we know if cancer patients are in pain when they come in? So I think realizing that, yes, a lot of these patients do have tolerance to opioids because they have taken opioids for a long duration of their life, but tolerance does not equal, you know, using it for untoward reasons. And so I give people benefit of the doubt. When they come in and they say they're in pain, I treat them as if they're in pain. Now, if somebody starts coming in every day, I think that's a problem, and I think that's when you need to work very closely with your hematology colleagues to say, you know, is there something more going on? You know, can we come up with a plan? Is there something, you know, psychologically that we need to address? Is there a housing situation we need to address? Is there some other reason that's driving them to come to the emergency department? Do we need to worry that they are just seeking opioids? But again, that's going to be such a small percentage of patients that it's really unfair to withhold pain medication from everyone because there is no objective evidence that says somebody's having a vaso-occlusive crisis. So I would much rather be burned by a few people who I give it to that shouldn't have gotten it than to withhold from a large percentage who should.
And I'll just follow up. The risk of not treating patients with a vaso-occlusive episode is high, right? We've reviewed with you today the complications that can arise during a vaso-occlusive episode or as a consequence of it, right? So acute chest syndrome, leading killer of adults with sickle cell disease and children. And so that can occur during a vaso-occlusive episode. So the longer we allow pain to be untreated, the higher the risk of untoward events are. So we really do need to, as Caroline said, we have to treat the patient in front of us. I encourage both the pediatric and adult providers in both of our EDs where we've worked closely with each other. You have to treat the patient and then secondarily reach out to the outpatient provider, whether it's a hematologist, a primary care provider, the provider who knows them best to really tease out what may be going on with this patient. But in the heat of the moment, treat the patient in front of you.
Okay, we're a couple minutes past the hour, so I want to thank everyone again for participating in this webinar. I want to hand it back over to Hillary at NHLBI.
Thanks, Dr. Wong, and thanks again for joining us today. We hope you enjoyed this session. If you have any additional questions, please feel free to send us an email to nhlbinews@nhlbi.nih.gov. Today's webinar does wrap up our NHLBI series, Sickle Cell Science, Path to Progress. Thanks to all of our partners and to all who listened and participated throughout this month. We will be posting all 4 of our webinars to the NHLBI YouTube channel very soon, and we'll be sure to email that link to all of you once it's ready. Thanks again for your interest and support during Sickle Cell Awareness Month. Have a wonderful day.